Good afternoon, everyone. Welcome to PYA's Healthcare Dealbreakers series. Today's topic is avoiding post-acquisition compliance surprises. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posted after the webinar via email. We will also have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Valerie Rock and Kristen Davidson.
Hello, everyone. Thank you for joining us for this second installment of our Healthcare Dealbreakers series. We're excited about getting this kicked off so that we can share with our private equity and venture capital colleagues in regards to our experience of boots on the ground as we work through these deals, because PYA has a lot of experience from across a wide breadth of work streams that we participate in with our clients, and want to share with you what we're seeing and what might help you mitigate your risk as you're looking to acquire whatever entity you're looking to acquire. Of course, our focus is healthcare, and we're going to talk about physician practices, ASCs, infusion suites, other areas like that. But even if you're not specifically in that area, our goal today is to bring awareness to the types of issues that you might see and what you could go ahead and address on diligence, or what you may want to mitigate as soon as the deal closes, so that you can address things before they become a real big problem. So we're going to share some of our experiences with that so you can prepare for that as well. So I am Valerie Rock. I'm a principal with PYA, and I oversee our revenue integrity services, and I am kind of in the weeds of our coding diligence and our compliance diligence, and I partner with Kristen Davidson in the operations pieces of that. So Kristen, you want to share your experience?
Sure. Thank you, Valerie. Good morning, everyone, and thanks again for joining us. As with Valerie, I'm also a principal and within our revenue integrity team, and Valerie and I kind of are the yin and the yang, if you will. She's the coding, billing, documentation, SME, and then I lead our operations team of conducting the diligence reviews and the clinical assessments as well. And so, as she said, lots of experience in conducting these, have seen a lot of good things, have seen some things not so good, and so we wanted to share kind of our experience today, and hope that you can prevent and learn from our experience as well as you embark on a potential acquisition.
And as you're learning, what you're hearing today and across the series, we invite you to share this with your business development teams, with your compliance teams, with your C-suite, with your board. There are a lot of people within your organization that could benefit from hearing this content. So, this is something that we've set up so that you can listen to it in a commute, on the way to work, or in any type of avenue. So a great way to get some content in as you're going through your day. So again, we're going to talk about what we've seen boots on the ground from a compliance perspective as we're doing diligence. We're going to talk about our lessons learned from that, and then also diligence limitations, how the diligence always has to be limited to a certain extent because of the time frame and the budgets that are associated with doing these reviews, and then how you can take these concepts and turn them into best practices. So from a common issues perspective, sorry about that, one thing that you'll see is we're going to talk about the technical issues that we see, but what you'll find is really this comes back to people, and we're going to tie all of this back to the human capital aspect, the culture aspect of the entity that you're buying, because if the people are, if there are leadership issues or if there are people issues within the organization and they're not aligned in culture and values along with your organization, then there's going to be people that are not necessarily doing the right thing. Maybe they're even motivated to not do the right thing. And so we see issues such as clinical issues. Often this is seen after diligence, because often the clinical issues are not a part of, or the clinical piece is not part of the diligence process on the front end. So things that we see are gloving issues, improper gloving between patients, that if they're not removing their gloves and adding new gloves between patients, they're just washing those gloves between patients. That's a problem. Sterilization techniques, if they're circumventing the long process for sterilization and using flash cycles and things like that, then that can be a problem, both from a just pure patient issue problem, but also it is an issue in certification, for example, for ASC. Age of equipment and building maintenance issues are often issues that are expenses that may not be seen on the diligence side of the process. So on the back end, there's large expenses that have to be accrued after diligence, and because the age of the equipment, that needs to be replaced, or because of building issues that need to be addressed to make sure they're up to code, for example. Wearing socks in the OR is something from a non-clinical person's perspective may not sound like a big deal, but it is a problem because it exposes a provider or a nurse to potential injury or potential bloodborne pathogens from that sterile environment that's supposed to remain sterile. So it's like these low-hanging fruit things that we see when we're doing clinical assessments and we're inside the OR and looking at what's going on from the patient from front to back and seeing all of these things occur, then we can tell where these potential issues are.
So one quick comment to add to that, and you don't have to go back, but I just wanted to add to the wearing the socks in the OR, because the layperson may be thinking, why in the world would someone wear socks in the OR and not have shoes on? And it was during a surgery. They were controlling a device with their foot, and so it was a touch point. They wanted to be able to feel the device better during the surgery. So just wanted to add that commentary there for those wondering.
Right. Which would be, okay if they put their shoes right back on, but walking away from that afterwards is not as good. So medical necessity is something that we see from two perspectives. So in one perspective, you're thinking of the payer policy, local coverage determinations or national coverage determinations that state that there are certain things that have to occur prior to a procedure, that if those things do not occur, the service is not billable. The other avenue is from a just clearly scope of practice, what is appropriate to do for a procedure generally amongst the industry. If you talk to 5 physicians, what would they agree on are clinically appropriate to do for a procedure? If there are high frequency of services that would be deemed not medically necessary, that is one area that we see that could be an issue. If the patient flow from the physician clinic to the ASC is not proper or is less efficient, sometimes the practice believes that they can bill all of the encounters with that patient, and oftentimes those services are actually bundled within either the procedure or the evaluation and management service at the beginning. And so billing all of those services uniquely ends up with an overcoding problem. And the new technology and investigational use is something that we see as something missed, because oftentimes these are billed to the patient. So the patient pays for these new technology services because they're not covered by the payer. So then the patient pays for that. So what's the risk in that? And really what the risk is if you have a at-risk population, maybe an elderly population that is targeted for a certain type of service, and you provide that service at a higher frequency than it would be deemed appropriate, and you're billing those services at a high charge, and basically kind of gearing towards a gouging type of scenario, then you have an issue, even though it's not a payer issue or a government payer issue. So looking for those even cash pay scenarios is important. Unlicensed providers is something we're going to talk about in one of our scenarios. Physical therapy assistants, therapy aides, medical assistants, and other auxiliary staff, if they're not licensed and should be based on the state requirements or the payer requirements, then if they're not and they provide services to the patient, then those services would be deemed unbillable. And that's where you end up with an overpayment. Practicing out of scope, then of course, is the same thing. So services have to be medically necessary, within scope, and under the appropriate licensure to even be deemed billable at a bare minimum. So that's where we can get into issues there. Turn it over to
I'll pick up, yeah, thanks. So I'll pick up contracting. Something that's important to evaluate during diligence is really looking at all of your third-party vendors, your third-party contracts, ensuring that the contracts are not only present, which oftentimes they're not, and for those that are sharing PHI, such as collection agencies or outsourced IT vendors, that there are appropriate business associate agreements in place. It is not uncommon to have a collections agency engaged in a practice and there not be any BAA in place, or contract for that matter. And if there is a contract in place, then it's the collections agency telling you what they're going to charge you to handle this for you. And so you want to make sure those contracts are present, that a BAA is in place when applicable, and then looking at the terms of those contracts, evaluating that, ensuring that the terms are compliant, that the third party is compliant with the terms of the contract of the services that they're providing you, ensuring that you're getting the services that you're paying for. And then also looking at, provider. We have an entire division at PYA that evaluates and can structure physician compensation arrangements. And something that's come up is ensuring that these comp arrangements are structured for the post-close environment, but then ensuring that those terms are actually complied with, particularly when there are changes involved there. So it's important to have the ongoing follow-up and the auditing of those contracts to ensure compliance with those physician comp changes. And then looking at lease arrangements. We're going to talk about real estate here in another slide, but ensuring that those lease arrangements are in place as well. And again, compliance with the terms of those contracts.
So when we get into billing and coding matters, this has become an area that has become a focus in diligence, whereas 10 years ago, people rarely did billing and coding reviews, but now it's just a common theme of what's done, because it's been determined that this is the area that can just basically take you out. If you have a large overpayment or you have a government investigation and things like that, those things can be very significant to the entity's viability. So kind of the normal things that you hear about are the overcoding and unbundling matters, but some things that you don't hear about as much about is unsigned orders or improper order entry, supervision, and quality of documentation. So each of these are things that we see somewhat routinely, enough to where we would want to make sure you're aware of them and looking for them in advance during diligence. So unsigned orders, we're actually going to give you an example of that here in a minute, but unsigned orders and improper order entry, you can see if something is signed or not in a coding review, but you can't see who signed it all the time in a coding review. So who physically actually clicked on the signature approval is not seen during that coding review. It's not until you are on the ground and seeing the processes that are occurring for that order entry that you find out that the nurse is actually using the physician's login to sign off on that order entry, for example. Supervision, where you may have an infusion suite and the physician is not actually on site or APP is not on site to supervise that service. Or quality of documentation. What we find in physical therapy and infusion services, when a payer is looking at those services, they're often looking at them from a clinical perspective as opposed to just a check the box on a coding perspective. For example, in physical therapy, there's a care plan, and you have continuity of care within that care plan, and you have a status of that care plan, and where are you progressing through the care, and is it appropriate to continue that care, as opposed to looking at just the modalities that were provided and the amount of time that was provided to support the code. So if you don't have the continuity of care documented, then the payer may say that those services are not medically necessary and try to recoup those. So we've turned our reviews into a more broader review in those PT services to make sure we're capturing that as well.
That's a great point, Valerie, that you make about the supervision, because that is something that, the coding and billing, as you mentioned previously, wasn't a priority. And now it seems that is often the only priority, because it's coupled in with financial diligence. And, we'll talk more about other diligence streams here later in the presentation, but it goes to say that the importance of the on-site assessment cannot be emphasized enough, because the on-site assessment gives you information that the financial diligence and the billing and coding diligence is not going to give you. And we've got a couple of examples of that, but you don't really know unless you have someone there, boots on the ground, truly evaluating how that practice is functioning, what their processes are in place. And those things are going to tell you information that you're not going to find in the data. And so as we look at revenue cycle processes, post-close, you want to ensure that, the good revenue cycle processes that are in place are spread across other locations if they have a multi-location organization. And then those processes that have been trained upon and improved upon are actually implemented throughout that. Looking at patient eligibility, oftentimes when I do diligence, they're not verifying patient eligibility appropriately or far enough in advance to mitigate any issues there. Ensuring that prior authorizations are in place. And if they're not, then those procedures are not proceeding. Ensuring that that's done. Eliminating the insurance-only billing. This is still a practice that is very, very frequent in physician practice offices of, it's the physician's discretion whether to write off the patient financial responsibility. It's an all or nothing. Either you have to write off all of it, or you're billing the insurance company and you're billing the patient. The key from a regulatory standpoint is you have to show a good faith effort. And usually that's 3 attempts. You send 3 statements. If you're not getting a response and that's documented, then you can write off. But you can't just write off that patient responsibility immediately and do what physician practices call this insurance-only billing. And then shoring up payment plans. Payment plans are loosey-goosey in physician practice offices. There are really no policies in place that outline the parameters of it, what the expectation is of the patient. Rarely do I find that patients are signing an acknowledgement of their responsibility for those plans. And so first out, day one, you want to implement a payment plan policy that clearly outlines what those parameters are, and that you're requiring patients to sign and acknowledge that responsibility. And then utilize your EHR function. Many EHRs now will have a payment plan function available where patients can go online and set up their own payment plans, which is good because you don't need to be keeping credit card information on file like in the old days. And so that eliminates keeping that PHI or that credit card confidential information on file. Patients can sign up for their own payment plans, and it ensures that regular payment until that payment plan is signed off. And then actually managing your AR. Instead of just sending out statements and hoping that patients actually pay, it's actually managing that AR, monitoring those collections, following up on that AR appropriately, and then monitoring credit balances. It's interesting to me that most physician practices that I go in, don't actively monitor credit balances. They say, oh, we don't worry about it. Medicare will recoup it. We're not concerned. Looking at patient refunds, ensuring that you're processing patient refunds. It's perfectly fine to apply that credit to a future appointment. That's not a problem at all. But if there are no future appointments and it doesn't look like they're going to be, then you have a responsibility to issue that patient refund. So it's because it's the appropriate thing to do, but also so it doesn't skew your financials in some way. Next slide. So we mentioned real estate previously, but looking at real estate compliance challenges, I believe that this is an area that doesn't get its adequate review during diligence and post-diligence. You know, looking at different real estate policies and procedures, ensuring that you have policies in place between the two entities. The various property management, you know, if we're looking at larger organizations, you know, Valerie mentioned at the beginning, we're talking about physician practices and PE backed as well, but some of those practices are very, very large organizations that actually have a real estate portfolio. So you want to ensure that there is a corporate structure that's implemented post-transaction that's going to manage that corporate real estate portfolio. So that's looking at various practice management properties, various accounting systems, ensuring that there are processes in place to combine those. Establishing that centralized decision making, having a leader established to manage that portfolio and that real estate function for the new corporate organization. Eliminating any silos, establishing that corporate structure that provides your single source of truth. We mentioned the contracts earlier, looking through those contracts, ensuring that the contracts are appropriate, that they're there. Looking at, again, supporting documentation for arrangements with referral sources. This is such a hot compliance area. And then looking at, during diligence, any violations or any issues that were found during the diligence process. Real estate needs to be included in due diligence just as any other diligence stream, because there are hidden compliance risks within the real estate portfolio that need to be assessed, evaluated, and then have a mitigation plan post-close, just like billing and coding do. So Valerie mentioned earlier the human capital aspect, and prior to PYA, I spent almost 5 years in corporate HR, and I can't emphasize the human capital aspect enough and the importance of including that aspect in the planning for the transaction. Because let's face it, the financials drive the deal, right? The money, it's where the money is, the financials drive the deal. And then, as Valerie mentioned, we've realized, you know, coding and billing are important to assess. On-site assessments are important to conduct during diligence. We look at IT, we look at other items, but oftentimes that human capital aspect is a last thought. And it should be a very important thought, because you can't be successful post-transaction without your staff on board. So they need to feel part of this, and they need to be communicated to early and often, and understanding that during pre-diligence, during diligence, oftentimes staff are not aware. They know something's up. Meetings are happening after hours. Individuals from outside the organization are beginning to visit the practice more often. So something is up. As soon as you can share the information, I encourage you to do so. And more times when I'm conducting diligence, that's one of the things we ask is your staff aware of the transaction? And more often I'm learning, yes, they are. They know that we are thinking about engaging in this transaction. And so that's great to know. Have the open forum for the staff to ask questions. Have your physician leadership present. Have your administrative leadership present. Have what we used to call in the hospital systems the town hall meetings. Have that open forum and give the staff the opportunity to ask any questions that they may want to ask. And if they ask questions that you're not obliged to be able to answer during that time due to confidentiality, then just simply say that. Be as authentic and genuine as you can with the staff, and continue to communicate with them. Continue to have that open forum, even if it's the same information. What's most important is that touch point. It's that opportunity to ask that question. And as they become more familiar with what's going on, they become more acclimated to the potential of the transaction, they'll become more comfortable in asking questions. And this is really important because when you think about developing that corporate compliance program and developing a robust compliance program, you have to have that culture of compliance. That's what the guidance refers to as a robust culture of compliance. And you cannot have a culture of compliance, a good one, without an engaged staff. And so the communication is the first step in doing that. So you want to be able to stand up that compliance program, have that engaged staff, offer the compliance education. That's the first thing that should be done right out of the gate on day one, is establishing and scheduling compliance education, communicating how staff can communicate any concerns that they have, offering that open forum of communication for staff to speak up. And then you can start engaging in other things such as training. If you identified during diligence that staff are not appropriate trained or they need additional education, then again, that's the time to start scheduling that and implementing that. And then that also refers to physician training as well. Oftentimes during diligence, we find during coding and documentation reviews that the physicians are not aware of the latest E&M guidelines. We're still doing education today in 2023 on the E&M 2021 guidelines because physicians have not had that education yet. And those 21 guidelines have been in place, 2 years now. We're also doing education on the 23 guidelines. And then that supports your corporate compliance program by establishing your coding auditing program or your compliance work plan, if you will. That's something, again, right out of the gate that can be done, is establishing a compliance work plan based off the coding and documentation reviews and providing that education to providers. And then also determining, what vacancies did you find during the diligence? Are there vacancies? Is there necessary training that's important to provide to the staff? Did you find inadequate processes in place and you've implemented new processes, so there's training related to those? And then looking at outsourced staff, particularly outsourced billing staff, outsourced IT staff. Those are the two primary staffing areas that I find outsourced, and determining, are you going to continue to outsource this staff post-transaction, or are you going to bring that in-house? And if you're bringing that in-house, what does that mean? What hiring do you need to do? What training do you need to do? What structure do you need to set up to be able to support those processes? And then if it will continue to remain outsourced, are those individuals adequately trained? Are they providing you the services that they should be providing you based on the contract present? So again, can't emphasize the human capital piece enough. So next we'll talk about EHR implementation. And I won't go into too much detail about this because in the first Dealbreakers webinar that our friend and colleague Barry Mathis provided, he talked about the IT perspective of that. And I encourage you, if you haven't listened to that webinar, go back and listen to it. It's an excellent webinar. People obviously are more concerned with IT these days, breaches, cybersecurity, as they should be. So I'll just touch on EHR implementation, but really it's looking at during diligence, the EHR, does the EHR support the operational flow of the practice? And again, another plug for that on-site assessment. Oftentimes you don't know unless you're on-site and you're monitoring and shadowing that flow of the office to determine, are there any potential risks in their processes of how they're executing? And so looking at the EHR, looking at, does the EHR support these processes in a way that are compliant? For example, we ended up and identified that an EHR during an assessment was on a very old version, wasn't supporting the operational process, and was actually through the physician documentation, if you will, and the drop-down menu selections, essentially, it was guiding the physician to assign level 5s. It was a high complexity that the physician felt, and it would automatically assign level 5s. And so this is where the ops diligence and the coding diligence work together, because the coding diligence is saying, why are we having so many level 5s? This is out of the ordinary. This is an anomaly. I don't understand. Well, the ops can tell the why behind the coding result. Why do we have so many level 5s? And so when we're looking at that and we're comparing that information and realizing, we investigate a little bit further and we find, well, they're not on an appropriate version. When we sit down and we're actually monitoring how they're assigning, the EHR was not supporting good compliant physician practice processes. Also looking at two-factor authentication, using old processes, templates, improper setups, shared logins. Yes, it still happens. As recent last week, Valerie and I were evaluating a recent diligence, and that was one of the findings, is the practice staff were sharing logins. There was no two-factor authentication in place. There was no monitoring of devices. There was no encryption on devices. So all of this still happens. And then also looking at your copy paste function. From an administrative standpoint, I began my career in health information management. Copy paste can be a nightmare for your coders and for documentation, and it actually can pose additional unnecessary risk to the organization. And so looking at, again, all of those electronic functions, how your EHR is operating and supporting your practice processes, and is there any risk hidden within that EHR and those versions. And then looking at risk overall, we talked a lot about, the human capital aspect of it, having and establishing a good corporate compliance program. Oftentimes what we're seeing is, staff are aware of issues. Again, that on-site assessment gives the opportunity for staff, if they have concerns and they've been communicating them previously and nothing's been done about it. It's interesting what you find out when staff have new people listening, new people that are engaged in the practice, that are interested to know how things are operating in the practice. Staff may have been afraid to speak up additionally in the past if they had done so and nothing was done, or they didn't feel their voice was heard. And so now they have new people, they're talking more, they have this opportunity for their voice to be heard. So again, it's important to immediately establish that corporate compliance program, to immediately provide that training, as it relates to compliance, the ability to speak up, having that open forum, and then ensuring, the HIPAA training, as we talk about, the HIPAA, the IT security training, the OSHA training, all of these trainings that should be happening for staff within practices. And then having the avenue and then listening to what they're saying. The worst thing that can happen is for them to have an opportunity to share their concerns to new people that are interested in the success of the practice, and then nothing be done. So you don't want to create a situation for potential whistleblowers in this sense, and by not listening to what the staff are saying and having that hidden risk within the organization.
So now we're going to shift over to our hypotheticals, our scenarios that are kind of somewhat of what we've seen out there without specifics to any specific client. But we'll start with that PTA scenario where an issue was raised, kind of like what Kristen was saying, where you go and you start a practice, you've acquired this practice, you're getting them all geared up, and now you've established a hotline, and now they're using that hotline and telling you what's going on. And a hotline call came in that there were some concerns at this one location that some unlicensed providers were providing services to in a PT scenario. So when the team went in to look and see what was going on, it was found that a manager had hired some unlicensed physical therapy assistants and was utilizing them for services along with the PTs. And they were kind of combined services together. And the thought for them was that the PTs are overseeing those services, so they're okay. But because those PTAs need to be licensed, the services provided by those PTAs would now no longer be billable services and would need to be refunded. So an initial reviewer went in to look at those services to see, what the documentation said. And the documentation was not really clear all the time exactly on what the PTs were doing versus what the PTAs were doing. So that reviewer determined a methodology to assess, what the percentage, for example, was of the services that needed to be refunded. And because that methodology was somewhat created, an additional reviewer went in and looked at that and confirmed and validated an agreement on how to refund the government for those services. And so a refund was made under self-disclosure for the services that were rendered by these unlicensed providers. But this goes, the lesson really learned here is making sure that you're looking at both the state guidance and the payer requirements for the licensure for all of your providers, and ensuring that not just the title of them is appropriate, but that they're actually functionally licensed at the appropriate level, so that they can provide services and so that money that you're receiving can stay within the coffers, right? So the next scenario is related to physicians being assimilated into the documentation standards. Oftentimes we see, with EHR implementation, maybe you want to get everyone on the same EHR, but you have some providers that are resisting that. And in this scenario, the providers are resisting moving from paper documentation into this EHR and want to use their same templates that they were using previously, even though during diligence it was identified that there were issues with the coding relevant to those templates. Well, they had a bonus structure that, about 12, 18 months out, that they were going to do a true up and make sure that, everything was still, okay at that point from a coding perspective. So another coding review was done, and it was found that because the providers were using that same template, the issues remained. So the issues had not been resolved, even though education had occurred and, that kind of these routine functions had occurred. The coding review 12, 18 months out showed that actually the coding had not changed. So the resistance by providers to move to the EHR to get into alignment, or to at least have accurate coding and documentation on the back end of the deal, reduces that, or doesn't address the risk on the other side. So just doing education, I think this is really what the lesson is. Just doing education doesn't resolve problems. Getting down into the templates, making sure that they're accurate and really driving good documentation, making sure they are moving to the EHR that you're on, and best utilizing that EHR, and that they don't have issues on that EHR. Because the EHR issues and getting the claims to the payer and things like that all can, create havoc within the practice, and may not be known until a later date. The third scenario, it gets back to that infusion order entry issue. In this scenario, we have a practice that has an ASC. And the physician is at the practice sending orders, an infusion suite. And the physician is requesting infusions by the infusion nurse through a notes function of the EHR. And in that notes function, there is no signature functionality like you may have in an EHR, where an order entry is created and the details are provided for that order entry, and then the physician signs off on that. Because this notes function was being used, there's no signature. Well, that was found in diligence, right? So we confirmed that there was a problem there, and that there was an issue with the infusion services. But as the internal team of the platform continued to learn more about this function and shift and change this function into a proper function for that signature, it was also found that there were clinical issues. There were issues between how the weights of the patient were being captured and the relevance to the dosing that was occurring for those patients. And if you don't provide the right dose for the weight, of course, of that patient, then you are either over or under dosing that patient. Similar issues were found along that line, to the extent that that platform then decided ongoing or in the future that they're going to include a clinical review as a part of diligence to make sure that these things are occurring on the front end. Because of course, if you're potentially harming the patient or don't have documentation to support proper dosing and things like that, that could come into issue from a payer perspective, but also can have a patient harm issue, and malpractice and other things like that could be at risk. Kristen, the fourth scenario?
Yes, this is my favorite part, is talking about the scenarios. And so again, the importance of the on-site assessment, and oftentimes we hear, well, companies want the coding and documentation review, and then we talk about the on-site and they say, oh, well, it's not going to matter because we are rolling up the organization and they're going to comply with our processes anyway. Well, that may be the case, but there are still risks that are in the current processes that you are assuming or acquiring. And again, that on-site tells you things that the financials can't reveal, and this is a perfect scenario of why. This was another situation where the physician practice also had an infusion suite, and evaluating that infusion suite, and then learned that the infusion team also provided infusions on the weekend. They want to serve their patients in their community. They understand that patients, not all patients can come during the week or during regular office hours, so they had Saturday infusion days. Great offering to the patients. The problem is that they were not appropriately supervised. So during the week, there was appropriate supervision. There was either a mid-level provider present or a physician present to supervise those physicians and be on site. On the weekend, a registered nurse was administering those infusions unsupervised. And so this is something that would not have been identified in the coding and billing, because in the coding and billing side of it, when you're looking at the data, it's being billed appropriately. There were no findings as it related to appropriate documentation and billing of those infusion services, because they were being billed under what was thought to be a supervising physician. So it was that on-site assessment that identified that. And it's so interesting, because when we do on-site assessments, we're following through the process, we're asking a question, and we're learning that, oh, well, that's nice, you offer that on Saturdays. And it's a simple question of, is it the same team that offers? Oh, well, the nurse is here, but Dr. So-and-so isn't here. I'm sorry, can you repeat that? So it's oftentimes the simple little questions that you ask that identify potential risk in the organization. And so obviously the resolution, this was something that was immediately stopped until they could get appropriate supervision scheduled for those weekends to be able to continue to provide that service for their patients. And that's something also that I find in diligence is the intent is always good. The intent is always good to serve the patient, to do what we can to either serve the patient or to support the physician in a way to be most efficient in order to serve the patient and to provide that quality care. So the intent is always good, but there's still potential risk in that if it's not handled appropriately. And then the last scenario we had is related to the clinical assessments for the ASC. So this was a situation, and two different examples here of during the on-site assessment. In looking at this, was found that the scopes that were used for endoscopies were over 15 years old. So is this inappropriate? Is this a patient risk factor? Well, is it a best practice? Absolutely not. And more importantly, is it impacted the deal because there was a cost associated to replace these scopes post-close. And in this particular scenario, this was a very large, high number of locations of ASC. So there were a high number of scopes that needed to be replaced post-close. So this was a cost that was factored into that post-close expense. And then also in another situation and scenario of conducting a clinical assessment, there are two examples of inappropriate use of the autoclave. So in one, the machine wasn't functioning correctly on its normal cycle, but the flash cycle worked. So the staff were constantly using the flash cycle as routine everyday occurrence, which is not how the flash cycle should be used. And then the second scenario was during the on-site assessment, the ASC didn't have enough trays. They had instruments, but they didn't have enough trays to support the surgery volume. And you think, well, this is a quick fix. Let's just order more trays, right? And that's exactly what they did. But again, it's these on-site assessments that find little things like that that need to be corrected going forward. Valerie, you want to talk about diligence limitations?
Yes. So let's get into how the diligence is limited, and we talked about at the top of the discussion about we can only do so much at the beginning of this diligence. The budgets are constrained, the time is constrained, and really you're not trying to get to know everything. You're trying to get to know enough to determine whether the deal is viable or not. And so one of the aspects of that is the actual documentation that's being reviewed, for example, in a coding review. When we're looking at the documentation, as I mentioned, we can see that something is signed or not, but we can't see who signed it. We cannot tell who actually logged into that system to actually do that documentation. So we may see something that looks completely fine on the surface and on the documentation, but when you find out on site that the functionality or the process that's actually occurring is different than what you're seeing on paper, then that can become a liability or a documentation issue or an overpayment issue that you were not aware of just from the coding review. In addition to that, the sample size is also a factor. And of course, we're not trying to do a statistically valid assessment when we're doing diligence. That is not the goal. But it also should not be used. The results of the documentation review or coding review should not be used to extrapolate over into the financials either. So we're trying to get a sample size that says, here's the potential areas of risk that you'll want to mitigate either, during the structure of the deal or post-closing, in education and modifying templates or modifying EHR uses or, additional training of the staff on how to document things, et cetera. But you would not want to use that as a direct tie as those results, like a 5% error rate, as a 5% reduction in revenue going forward. Now, we can look at it and tell you if those coding issues can be resolved on education. We can look at those issues and say that those coding issues will, after education, result in a reduction of revenue. But actually determining the amount is more difficult because oftentimes the assessment is done based on a risk-based sampling and a small sample. So we're looking at the highest risk services and a small sample of those services. So just be mindful of the tie-in to the financials going forward. Then delayed mitigation is another factor. So if you are delaying mitigation on these issues, say you're trying to get into onboarding processes, but you've acquired several practices at once and it's going to take you a few months to get to each of them, and you say the mitigation, the education, the coding reviews that need to be done, the onboarding training and things like that, the compliance training, letting them even know that there is a hotline, that all of that stuff is delayed. And so the practices that they were doing that were found during diligence will have continued during those months. So the things that you may have carved out from risk retrospectively will still be present in your active, current, and future services unless those are mitigated and addressed quickly. So really work towards getting the high level things addressed as quickly as possible, so that you're not addressing those later down the road at a high volume because so much has occurred over time.
Great points. And so continuing to talk about insufficient diligence, compliance overall, we know in the compliance industry and world, compliance is not a revenue generating department. And oftentimes when financials or resources are called into question, compliance is often what gets cut, right? And it's important that, we talk about having a robust compliance program, having a hotline. It's important to point out that, in the compliance world, we say that compliance is not a one size fits all, and it's not. And so when you're looking at, physician practices of any size, it has to be what is appropriate for that practice. So we've mentioned hotline several times. Well, a small physician practice is not going to have a third-party hotline. But what's important is that they are communicated that there is an avenue. There is an avenue to report compliance concerns and to who. And so even for those small practice acquisitions, sometimes I think that the smaller practices are, oh, we're so small, we don't have the resources to do that. We're just not going to do that. But you can do what you have resources to do. Compliance training is one of those. Having that avenue for communication again is one of those. Having appropriate processes in place to ensure compliant operations within the practice, you can do. And so it's looking at what you can do with the resources that you do have and ensuring that those employees are aware of those compliance efforts. Again, we talked about, having the employee that has the new ears, to talk and to communicate to, those are your largest potential whistleblowers in a transaction, particularly when they're not communicated appropriately with. So it's ensuring that there is a strong relationship with that team. And it's also looking at, ensuring that, pre-diligence was thorough and complete, and you're following up on things like licensures, ensuring the verification of that, ensuring that they're being monitored, looking at government healthcare program enrollments, ensuring the compliance with those, interviewing key employees. I'm a big fan from an HR perspective, if you can, of meeting with each employee individually, hearing their concerns, hearing what they have to say about it. But again, ensuring that, those avenues are open and receptive of both ways when you're conducting that diligence, because it can pose potential risk during and after the transaction. And then talking about auditing and monitoring, I mentioned earlier about immediately developing a coding audit work plan with the diligence findings. We'll talk here in a minute about some other implementations post-transaction, but FCA violations cost a lot more than implementing a good compliance program and a good auditing and monitoring program. And there is no excuse to not have a coding, auditing, monitoring program in place. There are available resources if you have staff internally that are certified in shoring up those processes, having a formal policy in place, having ongoing monitoring, having documentation of that, because it's important. If you ever are investigated by a third party, you get credit for the compliance efforts that you've made. So having a compliance plan in place, having a compliance audit work plan, which is typically coding auditing in these scenarios that we're talking about, having that in place is very, very doable. And again, you get credit for the compliance efforts that you make. So moving into some industry best practices. Again, we talked about, reviewing those diligence results, determining, what needs to be done. And I will tell you, a good diligence report, you should immediately be able to identify what your risk is, what's a priority, and what you need to do day one. Even prior to the closing date, you should have an integration implementation plan in place that says, here's what I need to do day one. And a good diligence report is going to be your roadmap to be able to do that quickly and efficiently. A good diligence report, as we talked about, you're going to have that coding and documentation piece. As always within compliance, your revenue cycle is your greatest risk. So you're going to have that coding and documentation piece. You can go ahead prior to close to have education set up to provide to those physicians, those mid-level providers, and the coding and billing staff for that matter. We encourage a collaborative education of that so they can understand from the front end to the back end of the physician assignment, which is typically what's happening, to the code assignment, whether they have in-house coders or not, or billers, and understanding that process. But a good report's going to have that. They're going to have your operational piece of it to understand what operational processes need to be corrected, implemented, mitigated if they're doing them wrong. And then if there's an ASC involved, having that clinical assessment. When you have all of those three facets, a lot of that training can be done in a much more efficient manner because you know exactly what needs to be done immediately. So a good diligence report is going to give that information. You have that provider education, you stop any processes that are immediately posing risk to the organization, such as unsupervised infusions on the weekend. That's an easy thing to immediately stop and correct. And then looking for that education, and again, having that prioritized coding work plan in place. And then if we haven't mentioned it enough, culture and human capital are key. So we talked about the importance of that. We had talked about the importance of employee engagement. I encourage you to have a formal communication plan as it relates to the transaction. And then in this particular aspect, as it relates to culture and human capital, I encourage you to pause, as particularly for new platform companies, to pause and really wisely think about who your leadership needs to be as you grow and scale that platform company. What I see sometimes is upon the first acquisition, again, what did I say earlier? The financials drive the deal. So you think, well, I've got a good practice here. I've got a practice that's, the revenues are good, they're very profitable, so all of their operational processes must be great. Otherwise, their revenues wouldn't be so good. Well, that's not necessarily the case all of the time. As we've talked about through the presentation here today, there are hidden risks within those financials. There are hidden risks within those operations. And so think wisely and ensure that you're getting the best leaders and that you're placing those leaders appropriately in the new organization. Perhaps the best placement is for them to stay where they are. And continue to learn and grow and identify any findings during their own diligence, implement corrective action plans for those to mitigate those, perhaps educate those leaders as well. And then as you grow that company, it's important to have thoughtful and wise placement of the leaders in the organization.
So thank you all again for joining us today, discussing these compliance topics that we're seeing within deals. We welcome any of your questions regarding this topic or any other topics regarding any acquisition or due diligence services, and we welcome any ideas that you have that you want us to present in the future. Let us know what you need to hear, what you're questioning, what your deal teams need to understand, and what your board needs to understand. We're happy to provide any of that content and share with you what we're learning along the way. So I'll turn it back over to our moderator to close this out, and we welcome you in our future webinars.
Well, thank you so much to our presenters, Valerie and Kristen. Later today, you will receive an email with their contact information and a recording of the webinar. Also, all the information on this and future episodes of PYA's Healthcare Dealbreakers series is available on the Insight page of PYA's website, which you can find at www.pyapc.com. While at our website, you may also register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions that you may have. On behalf of PYA, thank you so much for joining us and have a great rest of your day.